Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health Center, reporting for the week of August 8th, 2022. There is unfortunately a lot going on right now in public health, so I will be doing a COVID-19 update, a brief polio update, as well as a monkeypox update. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Currently, with COVID-19, we are finally starting to see some signs of a little downturn here. This is an improvement over last week when I reported we were at 9,451 cases on the 14-day totals, and now we are down below 8,000. So it does appear that we're heading in the right direction there. The percent positivity is almost the same as when I reported last week, still quite high. So we're going to be looking to see that hopefully coming down. Hospitalizations, we still just seem to be kind of zigzagging in the same area, which is not in a great area. Last week, we were at 167 in the hospital and 21 in the ICU. We're now at 161 in the hospital and 23 of those are in the ICU. So still much higher than we would definitely like to see it, and kind of just this sort of painstakingly long plateau that we're seeing in both cases and hospitalizations is coming down slower than we'd like. Hopefully we'll see it pick up the pace in the coming days, because right now we are still seeing a lot of deaths in the United States. We're actually now at 500 deaths per day. So that is like 3,500 people per week. This is a lot of death that we're still seeing from SARS-CoV-2. And we know that deaths do lag behind. So we see cases, then we see hospitalizations, then we see deaths. So we will just be watching. But right now we're seeing a little bit of an uptick with the deaths, at about 500 people in the United States still losing their lives to SARS-CoV-2 every single day. So this is something that we need to see improve. And in terms of what we're seeing with the variant proportions, unfortunately, we've got another variant of concern that has made it on the scene. It is called BA.4.6, and it is this blue color here. And so you can see it was in small amounts, and it is now clear that it is increasing exponentially at a rate that is a little faster than the BA.5. We still don't know a whole lot about BA.4.6, but let's just suffice it to say that anything that starts to sort of take off and displace other variants has some type of advantage. We don't know exactly what yet. Could it be avoiding some prior immunity? Could it be somehow latching on our cells easier, and so on? These are things that we'll know more so with time. But we never ever want to see a new variant making it on the scene, because this is how SARS-CoV-2 is sort of staying ahead of us, is by continuing to mutate at a faster rate than we can keep up with it. And when you look by region, you can see that this is sort of in the Midwest area where it's really taking off for some reason. And so I think it will be important that we get more and more sophisticated at being able to pick up when these variants make it on the scene, and try our best to understand what these patterns are of how this is happening geographically, where we may be importing strains from other regions, so that we can try to do something to stay ahead of it. Because at this point, it's just like we are reacting to SARS-CoV-2 every step of the way, and it seems to still sort of be in charge. But nonetheless, we will hopefully be seeing and feeling a bit of a lull in the number of total overall cases, which would then hopefully lead to decreased hospitalization and death before we head into, fall and winter surge, which I know we're all bracing ourselves for. And so knowing that school has actually started already for Oakland Unified School District and other school districts, it has started early. I'm not sure why it has started so early. We know that when we have more mixing, we'll have more cases. And so that becomes definitely much more of a concern, especially in the winter time. So I'm hopeful that this month head start that we've sort of gotten in starting school here, August, we started much earlier than, before. So August 8th, maybe that means that we can take a longer winter break, which is something that we advocated for quite a bit last year, because that would certainly slow down transmission during the winter months when we know that we have a lot more respiratory illness, including SARS-CoV-2 and all of the mixing and traveling that happens over the winter break. And so we're certainly hopeful for and will continue to advocate for a longer winter break, because we do believe that that could have slowed down what we saw last year with the Omicron surge, and where we had some, unprecedented rates of both cases, hospitalizations, as well as death, as well as the largest share of children ending up hospitalized and with poor outcomes. So we're certainly hopeful that that is what's happening. But nonetheless, where we are right now is that schools are opening, and we know that there will be more mixing, but hopefully the downturn that we're starting to see now can continue for us for a little while longer. In California, we are still seeing that the unvaccinated are at this point 11 times more likely to die from SARS-CoV-2 than those who are fully vaccinated and boosted. So that continues to be a trend. And we can also see with hospitalizations that if you are unvaccinated, you're 11.7 times more likely to be hospitalized with SARS-CoV-2. And even cases. So I know that we all are, frustrated by the fact that at one point the vaccine really kept us from catching it, but now you can actually catch it when you're vaccinated, but it's not the same as if you're unvaccinated. So still, if you are unvaccinated, 7 times more likely to get SARS-CoV-2 than people who were fully vaccinated and boosted. And so all the way around, we see that we're going to have sort of a widening of this difference between how you experience things if you are vaccinated versus unvaccinated. And so there just isn't really any reason to not be vaccinated. But nonetheless, we do have some groups that are less vaccinated than others. And I wanted to highlight today by age, because we are talking about young people going back to school. And we can see that in the under 12 group is really where we have the lowest vaccination rates, but it's really picking up pretty nicely. And so hopefully we'll see this increase a lot more now that school's back in session. This is a good time to go ahead and get your child vaccinated, because that's the best way to protect them from catching it, from bringing it into the household, from spreading it to others who might be more vulnerable, or even from them having an unfortunate poor outcome or getting sick and going to the hospital and so on. And the 6-month-olds to 4-year-olds, we're kind of, plugging along here to almost 20% have gotten their first dose. And these are, of course, the last 2 groups that we've had authorization for. So it stands to reason that we're not quite there yet, but there's really no point of delaying anymore, because we have great data on safety of these vaccines. And, as I've just shown, much more likely to catch COVID, much more likely to get very sick or die with COVID. And we know that when children become hospitalized with COVID, they actually can get very, very sick. About a quarter of them require going to the ICU, even the little ones. And so this is something that is very concerning. And also wanted to remind, and I went over this in a lot of detail in a prior briefing, but the vast majority of children hospitalized for COVID were actually admitted because of COVID, admitted for COVID, 87%. So this is different from adults where they might be hospitalized for something else, and then sometimes we find the COVID. With the children, much more significantly, 87% that were hospitalized actually was because of the COVID. It's not a coincidence. So this is very concerning. And more than half of hospitalized children had absolutely no underlying conditions at all. So still to this day, we cannot predict who will do okay and who will do poorly with SARS-CoV-2, and this includes among children. If half of them who were hospitalized had no underlying conditions at all, none of us should feel, as though a child is not at risk of a poor outcome. And remember, it's not that you can only catch COVID once. We are seeing people with repeated infection. We don't know what all that is going to lead to, and we don't want to know. If we can help ourselves from finding out, let's protect the little ones. If they can wear a mask, that is the best way to prevent them from catching SARS-CoV-2, along with their vaccination. So vaccination and mask are two really critical layers of protection, especially as young people are back in school, back mixing, back in the lunchrooms. If they can eat outside, that is even better. We know that those lunchrooms are a place where a lot of transmission can occur. And so we want to have as successful of a school year as possible and as safe of a school year as possible. The other thing about COVID and children that we have to keep in mind is that the burden of COVID-associated hospitalization and death in children is higher than all the other pediatric diseases that we routinely vaccinate for. And this is because we vaccinate them. And so right now we see that COVID-19 is the number 4 or number 5 leading cause of death for pediatric age groups. It's the only infectious cause of death in the top 5 causes of death among children. So this is all very alarming. And so want to just encourage you to ensure that your children are up to date on vaccine, and not just the COVID vaccine, but all the vaccines. And that brings me to the next topic for today, which I never, ever thought I would be having to talk about. But here we are, and that is polio. So polio has been recently detected in a few places. And so we're going to just talk about that briefly, because this is sort of a little bit of a shocking development, because we were really close to worldwide eradication of polio. We were down to only 2 endemic countries. Those were Afghanistan and Pakistan. We were down to cases in the hundreds, just a few years ago. And so the fact that we are now seeing it kind of cropping up in a couple of places. We had in the UK, there was actually polio detected in the wastewater, and this was reported back in February. And then it kept being detected over subsequent months. They found actually a mutated version of the same strain that they found in February over subsequent months. This indicates that it was sort of spreading and mutating. And so these were wastewater findings. And then in March, the World Health Organization was notified by Israel of a child catching polio. And so that was in March. And this was an unvaccinated child who actually caught polio in Israel. And then just about a week ago, a little over a week ago, we got a confirmed polio case in a 20-year-old man in New York. So this is all very shocking, considering that the last time that we have, really had to contend with polio was pretty much in the 70s. It was really a big problem in the 40s and 50s. We've all at least heard stories or seen pictures of little people in wheelchairs and on crutches. Polio can be a very severe and debilitating illness. Not in everyone, but in 1 in every couple hundred people, it can actually lead to paralysis. And so this was one of the one of the successes or almost successes of public health, that we practically eradicated it. The last wild polio infection that we had in the United States was actually in 1979. Since then, we've rarely just kind of had it pop up, and usually someone who was traveling from another place brought it in, but we have not had circulation here since the 70s that we know of. And the last even case that we had at all was in 2013. So almost a decade ago. And so the fact that at this time we now have a confirmed polio case, this was an unvaccinated 20-year-old man. The sample was determined by the state, the New York State Health Department lab, and then confirmed by the CDC's lab that this was likely a polio strain that came from the oral polio vaccine. Now, we don't give the oral polio vaccine in the United States anymore. We've been doing injected really for a couple of decades now. We stopped giving the oral polio vaccine. Oral polio was, very convenient. You could drink it, and there are still some places in the world that do use it because it's easier than injecting. But really, the only cases that we usually end up cropping up with are from the vaccine itself, maybe in someone who is shedding the vaccine and then can spread it to other people. And so that oral polio vaccine, there is shedding. I did a whole briefing on the fact that there is no shedding with the COVID vaccines, a very different phenomenon. There's also no shedding with the injected polio vaccine, which is the one that we give here in the United States. But there are some places in the world that still give the oral polio vaccine. So it can be a recipe for a problem when you've got unvaccinated people around. So if you're vaccinated and you live in a house with someone who got the oral polio vaccine and they were shedding, then you would not get polio. However, if you were unvaccinated, then it's actually possible. So in this case in New York, it was an unvaccinated young man who contracted a strain of polio that seems to have come from a vaccine. So they were in contact with someone who was being vaccinated with the oral polio vaccine. But the concern is then after that, they found 3 positive polio samples in wastewater in the same county. This is Rockland County. And then they found 4 positive samples in the wastewater in Orange County, which is adjacent to Rockland County. So we're still in New York, about 30, 35 miles outside of New York City. So, and these sewage samples were genetically linked to the strain that this unvaccinated adult caught. And mind you, this unvaccinated adult was left paralyzed, as was the child in Israel by the last accounts I could locate. So we're now having people be paralyzed from a virus that we had nearly eradicated. And this is just, a shameful situation that we're in. What I think we all need to be aware of is, yes, it's one case. However, those findings are really concerning that we could have local spread underway. You have a confirmed polio case, then you've got polio being detected in the wastewater all around the largest, city outside New York City. And what the New York State Health Commissioner, Mary Bassett, said, and she did not hold back. I'm going to read a quote. Based on earlier polio outbreaks, New Yorkers should know that for every 1 case of paralytic polio observed, there may be hundreds of other people infected. Coupled with the latest wastewater findings, the department is treating the single case of polio as just the tip of the iceberg of much greater potential spread. So unfortunately, the danger of polio is there in New York. Don't know if we need to be concerned about it anywhere else, but certainly we're concerned for local spread in New York. And I think we're concerned about what is going on, why is this happening, and if we have as New York State's health commissioner said, every 1 case of paralytic polio, there may be hundreds of other people infected. So what does that mean? The good news is that if you're vaccinated, then you should not have anything to worry about. The vast majority of us are vaccinated. We're vaccinated as children. If you or your children are vaccinated, you all have nothing to really worry about. There's nothing in your day-to-day life that needs to be changed. And remember, here in the United States, we only give the inactivated polio. So this is safe, effective, very effective vaccine. And it's given at 2 months, then 4 months, and then 18 months, and then somewhere there between 4 and 6 years old. So it's a 4-dose series for children. If you happen to be an adult that maybe was never vaccinated, that would be pretty unusual, but 3 doses will get you there. If you're not vaccinated, then, I think you really got to ask yourself why. Why are we risking paralysis? This can happen to a child. This can happen to an adult. And even folks who get it can sort of become progressively weaker or later need to become wheelchair bound. So this is quite a devastating thing that I had thought we left behind us in the 50s, 60s, 70s in that area. But we're having a little resurgence here. And I think the concern here is, is it possible that we have let our vaccination levels drop to the point where we are going to see something like this again? And I really hope not. I think that would be beyond foolish of us to find ourselves in a situation where we've got polio again. If your children didn't get vaccinated, if you didn't vaccinate your children for polio, or if you didn't get vaccinated for polio, then you have been benefiting from the immunity of those around you. And that can work fine if we don't have any circulating around. However, if this is any indication of a sign of things to come, then unfortunately, you won't be able to benefit off of the immunity of others, because you will be the available host for this and could actually contract it and get paralyzed. And I think as a parent, this would not be something I think it would be horrific. It would be a horrific thing to have to explain to your child who becomes paralyzed from polio. So we really need to make sure that we are getting into the pediatrician's office, getting our vaccinations taken care of, up to date. We know folks got behind during the pandemic, like we got behind with the dentist and everything else. But this is not something to play around with, especially when we've got this kind of cropping up in a major area of the United States in multiple wastewater samples. It's just rather unbelievable. So we really need to get a handle on it. So please, get up to date on those immunizations for yourself and your children. And now we'll move on to our next outbreak situation, which is that we have a second global health emergency and a declared emergency in the United States of monkeypox. And so the monkeypox virus was set to be looked at for potential renaming. There's been sort of a call for renaming this thing because it just sounds so terrible. And it's kind of a misnomer too, because monkeypox, it can come from monkeys, but that's not necessarily the only reservoir, and it just sort of has a negative connotation to it. But as it turns out, it is very difficult to get these names actually changed. And so although the World Health Organization is apparently accepting suggestions for how to make a change that would be consistent with sort of where it sits in terms of the families of viruses and so on. But the process is very long. And so it looks like we are living with this name for a bit here. So I'm just going to call it MPX for short as much as I can, because I think that it's a lot easier to cope with MPX than monkeypox, and we are going to be talking about it for a little while, it looks like, based on where we are now. And so once again, California has declared it a state of emergency, United States and the World Health Organization. There are over 28,000 cases that have now been reported worldwide. This number kind of keeps climbing. And there are over 1,300 MPX cases in California. This number continues climbing as well. In the United States overall, we have over 7,500 cases of MPX and climbing. And it's been a little bit of a slow process in terms of getting testing ramped up, as well as sort of going from suspected to confirmed cases. There's some steps that are involved with that. But certainly it is here, it has arrived, it is spreading, and we don't really know the extent of it, but it's definitely heading just sort of in an upward trajectory. And while it was seeded, or the outbreak seems to have started in a population of men who have sex with men, monkeypox is not limited to any one group. MPX is spread by close contact with skin lesions, as well as through touching contaminated items like clothing or linens, also through respiratory droplets, such as through prolonged face-to-face contact with someone where you're not wearing masks. And so if you are taking COVID-19 precautionary measures in public, then you are, for the most part, protecting yourself from MPX. We still have a lot to learn about this particular mutation of MPX, because this is not the same one that we've been getting warnings about from our scientists in Africa for years. But unfortunately, there wasn't any significant response until now. And now it does appear to be spreading in a different manner than before, in the sense that we have sustained human to human transmission that is concerning, because we're not sure just how much spread has already occurred, because we have multiple sort of independent chains of transmission that have already happened. One of the concerns of MPX is that it can find an animal reservoir, and that's what we don't want to see happen, like let's say rats. And this is something that would be of concern. And actually, I should mention that one of the reasons why we were able to almost eradicate polio, and why there's still a chance we can, is because humans are the only reservoir for polio. So unlike SARS-CoV-2 and MPX that have animal, that have animal reservoirs in addition to humans, polio is only found in humans. So we can actually get rid of it. The kind of one of the situations we don't want to see happen with MPX is that it finds itself an animal reservoir. So we really do want to slow down and stop the spread of this virus. And the initial sort of symptoms of MPX kind of include fever, headache, muscle aches, swollen lymph nodes. So a lot like the early symptoms of COVID, actually a lot like the early symptoms of polio too, if you get them. And then with MPX, you end up with a rash. It may start out as flat, and then it kind of evolves into these blisters that I think we've all seen pictures of. And we're still learning some things. So with the infectious period, we know for sure that a person is infectious from when they've got a rash until all the lesions are crusted over, the scabs have fallen off, and a new layer of skin has formed. So that for sure is an infectious period. Now, what we don't know is how long after that maybe some people may be contagious. And we also don't know if they may be contagious before the rash itself appears. There's a lot of people working on this. There are some lines of evidence that that virus, there's replication competent virus that can actually be found in individuals before the rash breaks out. Is that enough to get to make someone contagious. Those are all things we're just going to have to continue to learn about. And we don't know if the infectious period or the incubation period is going to be different for different modes of transmission. But as I mentioned, there's more than one mode of transmission here. So we've got a lot to learn about each mode. So the respiratory droplets and the close contact. And we've got, a lot to learn about whether or if there is any asymptomatic spread or pre-symptomatic spread. We will still need to be learning about that. But in the meantime, if you were exposed to someone who has it, if you believe that you are high risk, and right now, folks who are considered high risk for the most part are those who have multiple or anonymous sexual partners. And also, I think for certain occupations, we need to be taking extra precautions. Right now, healthcare workers are still not being prioritized for the vaccine because we just don't have enough of it. But we do know that people who are handling soiled linen and things like that should have PPE. And so I think that workplace protections are so critical. They are critical for COVID-19. They're critical for MPX, but the interventions are a little bit different. And in this case, we are primarily concerned with that close contact. So we're really talking about more so your personal life, and certainly for healthcare workers who are in contact with folks who may have it, then obviously they're going to be wearing the full PPE. But I don't want to leave out janitorial workers, hospitality workers, people that are going to be handling linens and towels in gym environments, our incarcerated individuals who are doing laundry in the jail and prison settings need PPE if handling soiled linen, because we do know that that is one method of transmission. So I've reviewed where we are with the SARS-CoV-2 pandemic, with this little concerning potential polio popping up here in the United States, as well as the MPX outbreak that is really just sort of getting underway. But I think to sort of wrap up, what I want to say is that the biggest threat in our day-to-day in terms of infectious diseases really remains SARS-CoV-2. There's just no question about it. We're still losing 500 people a day dying from COVID. This is a really pretty unacceptable state of affairs that we're in. Part of this has to do with not having the vaccine coverage that we want. We still need more information about who all is still dying in terms of treatments and so forth, but we know that we could be preventing death if we are treating. So we can talk about we have the tools, but the tools only work if we use them. And so in terms of preventing yourself from catching SARS-CoV-2, this is the same as it was in 2020. Mask, distance, ventilation, and filtration in your indoor spaces, hand washing, sanitizing when you need to, but really it is primarily that top row there. We are masking, we've got good ventilation and filtration. We're going to be testing and isolating when we're positive. Remember this from, I think it was Monroe County. I like this here. If there's enough virus to detect, there's enough to infect. So if you are doing home rapid testing and you're positive, believe it. And if you are positive, that means you've got enough virus there to infect another person. So let's please properly isolate and get and test yourself. And testing frequently is definitely not a bad idea, especially with cases circulating the way that they are. We know we want to get vaccinated and boosted. And please, and this is how we get ourselves from this horrible 500 deaths per day to down to 0 COVID deaths, which is, I think, an attainable goal, is that we get vaccinated and boosted, and we make a testing and treatment plan. We are testing if we think we're exposed. We are testing if we get any kind of different symptoms. And we need to know when to confirm with the PCR. If you get a home test and you test negative, but you think you were exposed or you have symptoms, you might want to get that PCR. We're also recommending getting the PCR, which is much more accurate in order to have proof of a positive test in case you might need it later, which many people are needing to demonstrate that they had COVID if they end up being one of those individuals with long COVID or post-COVID issues that cause loss of work or disability, etc. So PCR confirmation is never a bad idea, but if it's positive at home, believe it and know that you are also contagious and isolate. The treatment plan. Are you someone who's immunocompromised, on steroids, on chemotherapy, had an organ transplant, is on medications that suppress the immune system from an autoimmune condition like lupus or rheumatoid arthritis or inflammatory bowel disease? You may be a candidate for Evusheld. Please tell your loved ones who may fall into any of those categories that I just mentioned. Evusheld provides 6 months of antibody protection against COVID. And if you do catch it, please inquire about treatment, particularly if you have underlying conditions. And Paxlovid is preventing or reducing the risk of hospitalization or death really significantly, 80 to 90%. Even if you're not a candidate for Paxlovid, which most people are, there are infusion treatments that can be used. So we have a lot of tools, but we absolutely have to use them so we can intervene on this situation of really an unacceptable number of people being hospitalized and dying every day. And that's not even to mention long COVID, which is still affecting too many people, and we don't know enough about it. We don't know who's going to get it. We don't know how to prevent it, and we don't even know how to treat it. So we're still in a situation where we are accumulating a huge burden of illness, hospitalization, disease, and death. And so although I do not like to see polio making it on the scene, I don't like to see MPX making a worldwide move here with the United States really taking off in terms of spread. But in terms of practicality and our day-to-day life, it's still COVID-19 is what we need to be certainly preventing from catching and preventing from dying. And so last but not least, if you don't have a primary care provider, please get one, make that treatment plan now before you need it, and maintain a balanced diet, get some exercise, manage your stress levels, consider a multivitamin supplement with additional vitamin D supplementation, and get a good night's sleep. If you have any comments or questions, please leave them in the chat or send us a direct message or email us at admin@rootsclinic.org. And this concludes the People's Health Briefing for today. Look forward to seeing you next Tuesday at 10 a.m. See you then.